everyone coming to join us today. I've divided tonight's talks into 3 sections. We're going to start by talking about the fundamentals of fracture fixation and how fracture reduction, stability, and biology all contribute to bone healing. We're next going to talk about several types of internal fixation and look at some x-rays with different types of plates that are demonstrating some of the principles that we're discussing. And finally, we're going to talk about how orthopedic implant principles can be very pertinent to the what, the why, and the how of fracture fixation. There are 3 gross processes in healing a fracture, and a little bit of this is stuff that you may recall from your first or second years of medical school, but I really want to make it relevant to what we do as orthopedic surgeons so that you can understand how this impacts both the decisions we make in the operating room and how well our patients do after surgery. So please feel free to use the Q&A function if you have any questions or any comments during the talk, and our moderators will help answer those tonight. So as I mentioned, there's 3 processes that are involved in healing the fracture. First, you have to get the fracture lined up, which is something we call reduction. Second, you have to get the fracture stabilized so that the bones can heal in the position you've put them in, and this is known as fixation. And the third category, the third process is getting the bone to heal overall, and that relies on biology. And we'll talk about how there are things that we as surgeons can impact, but how the patient's biology is very important in this process as well. In the next couple of slides, I'm going to demonstrate some different pathways to achieving each of these steps. So I want you to pay attention to 2 ways in each of these different pathways to achieve the desired goals. So we're going to start by talking about fracture reduction and how you get the fracture lined up. The first way is called direct reduction, and this is aligning the fracture under direct visualization. This is often known as open reduction because you have to actually cut the skin and expose the fracture site in order to get an open reduction. Then you can use your hands or instruments like the tools shown on the right side of the slide to manipulate the fracture. And the goal with direct reduction or open reduction is anatomic alignment of the fracture, meaning no displacement or no separation between the bones at the fracture site. The second type of reduction is called an indirect reduction. This is where we align the fracture without exposing the fracture site, and it's also known as a closed reduction. In order to get an indirect reduction, then we use manipulation remote from this fracture site, which is often outside the skin. So this could be something like traction, either traction that you're pulling or traction through a fracture table, through a traction pin, or through an external fixator. Or it could be ligamentotaxis, which is where you apply traction and then rely on ligaments that are attached specifically to certain fracture fragments to help line up the fracture. It can also be done through percutaneously placed clamps, which is what you see on the x-ray on the right. So these clamps that we can see on the x-rays were all placed through tiny poke hole incisions in the skin. The benefit of an indirect reduction or closed reduction is that it maintains fracture biology. So you're not exposing each of the fractures or the individual fragments, and this helps keep all of the metalloproteases and cytokines and everything involved in fracture healing within the fracture hematoma at the fracture site. And importantly, the goal of indirect reduction is different than the goal of a direct reduction, where the goal of an indirect reduction is acceptable alignment, which is not necessarily anatomic alignment. And what constitutes acceptable alignment is actually different for each bone, and it depends. You're at the articular surface, which we want to be as perfectly lined up as possible, or whether you're further from the joint. And certain bones and certain places in the body can accommodate for different amounts of displacement still. So the goal of acceptable alignment is a little bit different for each of the bones that you reduce. The next pathway toward bone healing is the fixation pathway. And this answers the questions of how do you get the fracture stabilized? And I want to talk about a couple different things. The first thing is that, help you understand that there are many factors that influence what kind of fixation we use to impart stability at the fracture site. And that depends on things like some patient factors, like age, for example. So is the patient skeletally mature or immature? You can understand how stability at a fracture near a growth plate might have different requirements than getting and obtaining stability at fracture away from the growth plate. A second patient factor is bone quality. Does the patient have a metabolic bone disease or have an underlying condition that may cause bone density or their bone quality to go down? And that may require a different kind of stability as well. Fracture characteristics such as fracture pattern are very important. Is this a transverse or an oblique or a comminuted fracture? Is there a butterfly fragment that should be fixed as well? The location of the fracture, as I mentioned, is also important. Is it in the diaphysis? Is it periarticular, meaning around the joint? Or does it involve the physis, for example? And other categories are things like the soft tissues. Sometimes when a patient is so swollen, the soft tissues can't handle an incision for internal fixation, where we think that an incision might be difficult to close, and that imparts a risk of infection to the fracture site. So in that situation, we often would choose something different, like external fixation, for example, or delayed internal fixation. But that's certainly a consideration when we're planning for fracture stabilization. And associated injuries are important. And in particular, we think about other injuries that are on the same limb that requires fixation, because that may change how you decide to treat the fracture as well. I'm sure you've heard of several types of fixation, and these are probably the most common types, but are certainly not the only types. And so the first one we think of is a cast, which of course is not a type of internal fixation. And you can imagine that a cast is only as good as the mold that's put on it and the reduction that's obtained. A second type is external fixation, which is where there's very limited internal fixation. You can see from the x-ray on the right that there's a what we call a Steinmann pin going through the calcaneus that is providing very limited internal fixation, but most of the fixation is in the form of a scaffold that's built around the bone to obtain provisional alignment. And then there are several types of internal fixation, which include but are not limited to intramedullary nail fixation and plate fixation, and these are demonstrated here. And for the rest of the talk, we'll be focusing primarily on internal fixation, particularly in the second and third parts of the talk. So as far as getting the fracture stabilized, it's important to understand how these types of fixation, from cast to external fixation to different types of internal fixation, differ from each other. And there's many subtleties, but two of the most important are by the amount of soft tissue disruption needed for placement, which varies from none for a cast to a large incision for certain plates, and by the amount of stability that each of these types of fixation confers to the fracture site and to the environment around the fracture. And that's what we're going to talk about next. So this notion of stability is a physics principle that we in orthopedic surgery talk about as strain. And strain is a measurement of the change in length over the original length of the fracture site. And what this is really is a relative measure of the deformation or the mobility of the fracture following fixation. And so we think about it as a continuum with kind of strain greater than 10% being that this implies that there's relatively little stability, and this could lead to a non-union where there's just not enough stability for any reasonable amount of biology to progress all the way to fracture healing. But in a low to moderate strain environment, meaning strain between kind of 0 and 10%, there's different kinds of healing that can occur. So absolute stability is stability imparted by fixation, where you fix the fracture with a construct that minimizes strain. And this low strain environment is usually less than 10%. And remember that this is a ratio, so it's a relative measurement. Whereas relative stability is fixing the fracture with a construct that allows a moderate amount of motion or a moderate strain environment. So it allows limited but controlled motion, kind of in this 2 to 10% strain environment. And so you'll see on this chart that the different types of fixation, both internal and external fixation, impart different types of stability to the fracture sites, where cast, which is completely external to the body, has the most relative stability, so the most motion at the fracture site, followed by external fixation and certain internal fixation constructs like an intramedullary nail or a bridge plating. And there's definitely things that you can do to narrow that window, to provide more or less relative stability even, depending on how you place your, the pins and external fixation, or what is the nail or bridge plate construct you use. So those things are under the control of the surgeon. These are things that we think about. And then from an absolute stability perspective, plating with interfragmentary compression is the really the best way to provide absolute stability. So this is where you have the very least strain or motion in the fracture environment following fixation. So before we talk about how the stability interacts with the reduction, then I want to just quickly talk about the biology. And this is probably the thing that most harkens what you learn in your first and second years of medical school, but I'll try to make this really relevant. No pathology slides, okay? So as far as the biology, this is what really gets the fracture to heal. So you can't do anything with without, this is not like a sawbones that we're doing. This is the patient, this process is happening in the patient's body, and it relies on their biology as well. And so there's really two pathways to bone healing. And the first one is called primary bone healing. And you recall that this occurs via intramembranous ossification, so also known as reversion remodeling. And primary bone healing requires a low strain environment. Remember, we talked about in the last slide, it requires very, very little mobility at the fracture site. And so on an x-ray, it's characterized by the absence of callus, okay? Whereas in contrast, secondary bone healing occurs through a cartilage model via enchondral ossification. And so this process requires a moderate strain environment where you have between estimated 2 to 10% of strain at the fracture site following fixation. And on an x-ray, it's characterized by the presence of callus. So this moderate strain environment is imparting some controlled but additional mobility than would be required for primary bone healing, but it results in secondary bone healing nevertheless through a different biologic process. And on x-rays, we can tell that this is happening by the presence of callus. And so I want to put these things together, and I want you to pay attention kind of to the middle and to the right-hand columns, because these are how these three processes, from the reduction to the stability to the biology, come together to create these processes that can drive a fracture to healing. And so the first pathway is this direct or anatomic reduction, where you visualize the fracture site, get things lined up anatomically, and then impart absolute stability through your implant of choice with a low strain environment that then progresses to primary bone healing through intramembranous ossification. And on x-ray, it's characterized by a lack of callus. And the second type is shown in the right-hand column, where you have an indirect reduction, which gives you approximate or acceptable alignment based on the reduction you get in the operating room, but also what you know to be acceptable for that bone, that location. And then imparts relative stability to the fracture site, where there's a moderate amount of environmental strain or motion at the fracture site, which is controlled, but certainly still there. And then this results in secondary bone healing through an enchondral ossification, which is that cartilage model. And as a result, what we see on x-ray is the presence of callus at the fracture site. We're going to talk about how to use different plates and what vocabulary we use and what are the goals of different types of plate fixation. But it's important to understand that, as Dr. Haynes mentioned, this is, you may also see different mixed modes of fixation or mixed modalities as well. And it's not necessarily wrong. It's a surgeon trying to adapt the fixation to the location of the bone and some of those other things to answer some of the questions that we talked about, what patient factors, what injury factors, what bone factors can all contribute to, what does the fracture need? All right, we'll keep the questions coming in the Q&A section, guys, and we'll move on to the next section. So we're going to talk about types of internal fixation. And primarily, I mentioned that we are going to talk about plate fixation and intramedullary nail fixation, but understand, too, that fractures can be fixed with percutaneously placed wires. In certain situations, they're fixed with arthroplasty or joint replacement. There's lots of other options as well. And so, but these are really some of the broad principles that we think it's important for you to understand, both as medical students, but also as junior residents. And then, of course, you'll build on this foundation throughout your residency. So principles of internal fixation. These are 4 principles that we as orthopedic surgeons really understand to be true and important. And certainly they've been modified over time. This is kind of the basis of what we think about in terms of what are the principles of internal fixation? What are you trying to achieve with the construct that you're building? So we talk about the first one being restoration of length, angulation, and rotation. achieving stable internal fixation, whether by relative or absolute stability, preserving blood supply. When we talk about biology at the fracture site, we're primarily talking about blood supply to the bone, and early active mobilization. So, having a stable internal fixation that then allows you to feel confident moving the patient. Now, this doesn't always mean early weight bearing, but it often means early joint mobility, because we try to stabilize particularly articular fractures or periarticular fractures in a way that then we can get the body moving postoperatively. So 2 points I want to talk about, because I think there's I think there can be some confusion about this. And the first is that the type of plate, we're going to teach you some vocabulary about different types of plates or types of fixation, but it's really important to understand that the type of plate is determined by its use or by its function, and that is determined by you, the surgeon. And so this is not something where, you say I'd like a bridge plate and you whip the bridge plate out of the box. This is something where you can, as an orthopedic surgeon, will learn to take a plate and say, what can I do with this? And how do I want this plate to be used based on what kind of function you want it to perform? And then it takes on the identity of the type of plate that it's becoming. And so we're going to talk about bridge plates, anti-glide or buttress plates, neutralization plates, and compression plates today. In some situation, you may notice that when you're in the operating room, how that plates are machined in certain ways. And so one example is whether they have locking holes or, for example, whether they are anatomic plates, which means they've been designed to fit in a certain location in the body. And so those plates, like how those plates are machined, can augment or can limit their use. But oftentimes those plates can still be used as a bridge plate or an anti-glide buttress. Again, you determine its function. You're just choosing a piece of metal out of the box. But it's important that you understand that sometimes the plates, how they're actually machined, can change a little bit their use as well. Either make them more or less practical for the particular fracture that you're facing. So let's start by talking about a bridge plate. You may hear bridge plates internal, external fixators, because they're constructs that provide relative stability to a fracture site, very similar to an external fixator. And you'll recall that on our continuum of stability, the bridge plate was pretty far to the left, which was the relative stability side. And that's because it's designed to be used with an indirect reduction. So you're not necessarily visualizing the fracture site. You're not choosing to get fixation in every single piece. You're searching for an acceptable, not an exact or anatomic alignment. So it's providing relative stability to the fracture site. And it's often employed in areas of comminution, where the plate is designed or placed in a way that spans the fracture site without obtaining fixation in each fragment. So you can see these are 2 femur x-rays on the right side of the page. The one all the way to the right is a convoluted diaphyseal femur fracture, where there's a large area of comminution centrally and kind of screws at the top and the bottom. But you can imagine that we're certainly not getting fixation in all of those pieces, or really even any of those comminuted fragments. We're just getting fixation proximal and distal to the fracture. And then in the image on the left, then you see a more distal, or what we call a supracondylar femoris fracture, where where that area is spanned by the plate as well. And so that's a bridge plate construct. And interestingly, you'll see a couple independent screws that are outside the bridge plate construct. And this is what Dr. Haynes was talking about when she says in different parts of the body, you may have a plate that's designed to be used in one kind of mode, but there may be additional plates or screws providing a different function in another part. And so I suspect that this patient had an articular fracture. It's important to get articular fractures lined up as perfectly as possible with anatomic or direct reduction and absolute stability. So that's probably what those screws were providing that are down there closer to the joint. So the next plate function we'll talk about is that of an anti-glide or a buttress plate. And the purpose of an anti-glide or a buttress plate is to prevent sliding or shortening during axial loading. So the idea is that and I hesitate to use the word, Sarah, to say that it neutralizes shear forces. I kind of regret that wording a little bit, because we have a neutralization plate that does something different. But the idea is that a buttress plate an anti-glide or a buttress plate will be placed at it creates an axilla with a fracture. And so an axilla is where you see that on the middle slide, or the middle image B, and basically it creates a corner between the plate and the bone. And so when the bone is axially loaded, then the end of the fracture will actually kind of compress up into that axilla, and it provides compression at the fracture site. And so these can be employed for partial articular fractures, like metaphyseal fractures, in which we call it a buttress plate, or can be employed for oblique diaphyseal fractures, like an anti-glide plate. And I would argue that this plate here would be considered an anti-glide plate because this distal fibular fracture is really an oblique diaphyseal fracture. So we could call this an anti-glide plate. But you'll see these words often, some people will use them interchangeably. So understand the idea of what you see on the slide all the way to the right, which is as the body actually loads, or as the person loads the fracture, then the axilla of the fracture gets pushed up into the, and creates interference fit between the bone, the unbroken portion of the bone and the plate. And that's what applies some compression across the fracture and provides some stability as well. So the next type of construct I want to talk about is interfragmentary compression. And so this is a little bit more complicated, but it's so important because this interfragmentary compression is really the best way to provide absolute stability to a fracture site. And so you start with, on the left side of the page, direct or anatomic reduction. So again, you can see our clamp is clamping the simple oblique fracture together. And then by getting an interfragmentary compression, then you can get absolute stability of the fracture site via either a screw construct or a plate itself. So you can use a screw to give you interfragmentary compression, or you can use a plate to do something very similar. And this results in intramembranous ossification through these little Haversian canals. And here's our obligatory pathology slide. But I want you to look down at the x-ray on the bottom right-hand corner of the screen. So this is the post-op x-ray from this guy. And you'll see, if you look closely, that there's still a little bit of fracture lucency. So this was our interfragmentary compression screw that was crossing this fracture site. There's a little bit of fracture lucency still, but you very subtly see that there's bone crossing the fracture site. So as opposed to a big lump of callus, you get a little bit of bone. But like Dr. Graves mentioned previously, there's still some periosteal reaction, which is what you see on that by the first screw. So there's still a little bit of change in the cortex. But really, as opposed to a very abundant callus response, then you just see that the bone is filling in on either side of the fracture site across the fracture itself. So this is what we look for in x-ray when we have this pathway of direct reduction, absolute stability, and then primary bone healing or intramembranous ossification. And so that's what we get with interfragmentary compression. So and you'll hear people talk about lagging the fracture, and that's another kind of the verb we use to talk about obtaining interfragmentary compression. And it's really the single best pathway to achieving absolute stability. And so there's 3 techniques, and we'll talk about a compression plate here, and then we'll talk about lagging by technique versus lagging by design, which uses screws instead of a plate. And we'll discuss actually that in the last section when we talk more about screws. But just remember that there's kind of these 3 techniques for obtaining interfragmentary compression, and that's what should always be associated in your mind with absolute stability. So let's talk about how do we get compression across a fracture site using a plate. And so this compression plate, which again, it could be any plate, but we are assigning it the function of a compression plate based on how we use the plate. And so this provides compressive forces across short, oblique, or transverse fractures. And this can be I think it's really fun, but it can be kind of tricky in the operating room to do, especially for transverse fractures. And so there's a couple different steps, and I want you to understand this and review this diagram. It took me a while, even as a resident, to kind of feel really confident that I was understanding this correctly and getting this right. So again, like with anti-glide or buttress plates, we're choosing to create an axilla between the bone and the plate. And the idea is that this plate screw construct is going to drive the oblique fracture into that axilla and provide compression across a fracture site. And so step number one is to attach the plate to the bone to create this axilla. So you have to be able to, kind of identify, well, which side do I want to start on? Which side needs to have the plate attached first to create this axilla when I can. Now, for a transverse fracture, you may not have a great axilla, but even then, most fractures are a little bit oblique where you can do this. Or if it truly is straight transverse, then you just choose one side. So attach the plate to the bone to create an axilla, and then this is your first screw. So first screw gets put in bicortically all the way across. Step two, so you place a second screw eccentrically in the plate. And I want you to look carefully at this little gold plate diagram that we had here. And you'll see that the holes in the plate are oblong. They're not, they are not perfectly round. So it kind of fits the screw head plus a little bit. And so we actually are going to place, drill the screw on the far end, eccentrically in the hole away from the fracture site, with the idea that as we then put the screw down, you'll see that the head of the screw engages with the plate and actually kind of really pulls the bone into the axilla, is really what it does. So let's see this one more time. So again, can you guys see my arrows here? Okay, so as the screw is coming down, it's going to encounter this edge of the hole right here, and it's actually going to kind of now then cause the bone and the screw are going to move together, right, to slide this way into the central portion of the hole, and that's going to help close down the gap, which provides a compressive force across the fracture site. So let's go ahead and look at a couple examples where this may radius fracture. So transverse fracture, relatively simple fracture pattern. You can see the fracture here, but the first screw is what we place is this guy right here, right? Just placed in the center of the hole in the plate. You can kind of tell that these plate holes are oblong, right? Because here's a screw in the center. You can see some air on both sides. So the screw goes in the center of the plate, and then the next screw is placed eccentrically on the far side of the plate, so that as the screw head encounters the plate, then it pushes this screw and the bone toward the fracture site, assuming the fracture site's right here in the middle, toward the fracture site, and that is causing compression at the fracture. And then you can actually repeat this a second time, which is, additional screws were put on this side, and then additional compression was obtained, okay? So this is how you can use a plate to compress across the fracture site. Same thing happened here. This is a very short oblique humerus fracture, and you can see that the plate was used holes are subtly oblong here. The plate was used to compress across the fracture site in this as well. Okay, so again, very appropriate for diaphyseal fractures, for short oblique fractures, or for transverse fractures. It's really, I think, where they have the most utility. Oh, there we go. Okay, last plate type we'll talk about is a neutralization plate. So a neutralization plate, the idea is going to neutralize torsional, which is a twisting, shear, or bending forces on lag screws. So again, we're going to talk about lag screws in the next section, but the idea is that if you get a lag screw across a fracture to obtain interfragmentary compression, then you want to protect it from these torsional, shear, and bending forces, which can be difficult for a single screw to overcome. And so the idea is that you get the fracture lined up, get interfragmentary compression at the fracture site, which imparts absolute stability, but then you need to protect it from these other forces on the bone, since one simple screw may not be enough if it's subjected to any of these other forces. And so in that situation, all you're doing is putting a plate with several screws on either side, because it helps protect it from torsional, shear, or bending forces. And this is simply called a neutralization plate. And so here's a couple examples. These are all interfragmentary compression screws right here. Or lag screws. We're using the lag across the fracture site. And these are just examples of some neutralization plates. So plates with screws proximally and distally on either side of the fracture that then allow give additional stability to the fracture site and help protect the screws from these other forces, torsional, the bending, and the shear forces. Okay, quickly, I wanted to mention the tension band concept, because you guys may hear of this as well. And so the idea of a tension band is that it converts what we call tensile or distracting forces away from the joint. So on the far side here, usually imparted by a bone kind of within or near a tendon origin and insertion, they turn into compressive forces at the articular surface. So the idea as shown here in the middle picture is that you have a tensile force, which is the force for this patella fracture of the quadriceps mechanism or the extensor mechanism pulling against the fracture site through the quads, through the quad tendon, through the patellar tendon. But then this tension band construct helps create a compressive force at the articular surface right here, which is really the area where is most important to heal. And so this diagram on the left, or I'm sorry, on the right actually shows what that might look like when you build it. And so here's some x-rays. I think it's helpful to recognize this on x-ray. And again, these are really tend to be used for transverse articular fractures or fractures at the bases of insertions of ligaments or tendons. So they most commonly used in the olecranon and the patella probably, but also you'll see them with some regularity in the medial malleolus or in the ulnar styloid. And it's a very similar principle to how we fix greater tuberosity fractures, even though that's often done with kind of an anchor type construct at this time. But the important thing is, more and more, I think the x-rays, actually both of these x-rays show this being done with K wires or Kirschner wires and like sternal wires or 18 gauge wires, like actual metal wire. But more and more what I'm seeing is that surgeons are using kind of synthetic materials that are often not radial, or they're often radiolucent, so not radiopaque. So what you may see are just wires or screws across the patella, but you have to be able to intuit that this is creating a tension band construct and they've just chosen to use a radiolucent tape instead of the metal wires. So just something for you to be aware of as well. And then to round out this section, I wanted to talk about intramedullary nailing. And the idea with intramedullary nailing is that you're, again, similar to a bridge plate, providing an internal-external fixator that provides relative stability. So it's designed to be used with an indirect reduction. You're not expected to or able to get fixation in all of the fracture fragments. And one of the benefits of intramedullary nails is that they can be inserted through very small incisions. And so for things like in the femur, where there's a lot of musculature around the bone, or in the tibia, which is, often has a lot of swelling and may not respond well to lots of incisions, then these are really, really helpful tools and a great way to obtain adequate fixation. And so, again, they tend to be employed for diaphyseal femur and tibia fractures, when plate fixation would require extensive soft tissue dissection, because remember, indirect reduction is usually done with external manipulation or very limited incisions, so it preserves the biology there. They are commonly employed in areas of comminution, where, similar to a bridge plate, where you're not going to get fixation on all the fragments with a single plate. And also for length, stable, or long bone fractures, and these tend to be newer implants. You may see people use either a newer proprietary nail for like an ulna or a fibula. Some people honestly will just use very large like pelvic screws. So you could use, a 110 millimeter screw and basically use it use it like an intramedullary nail by employing it in this fashion. And again, that kind of goes back to the thought of, well, you as a surgeon are assigning the function to the implant. Don't let the implant decide for you what you need it to do. One of the major benefits of intramedullary nails is that locked nails, which are nails that have bolts at the proximal and distal ends, so on either side of the fracture site, those are load-sharing devices that may, in many circumstances, allow early weight bearing. And some of it does depend on the fracture pattern, but there's more and more evidence that we can allow early weight bearing on intramedullary nails that are locked because you've created a rotationally stable and a length stable construct. So that is, and that creates a load sharing device. So again, allows patients to mobilize early, which is one of the principles of internal fixation that we talked about. So here's some examples. Again, these are from femurs and tibia, super common. So we see everything from kind of a segmental tibia fracture on the left with a wedge type construct, to another one there that's more of a distal fracture. But you'll see that these are all locked nails, meaning there's bolts at the top and the bottom of the nail. Then there's multiple different types of femur fractures as well. So lots of different nails, different screw constructs to configurations, and that's a whole nother topic, but something that you guys will learn more and more about in residency as well. Just round out the talk by talking about fundamentals of orthopedic implants. So I'm going to talk a little bit less about kind of the function, you as a surgeon deciding how you want to use the plate and what are some different ways to do that, and talk a little bit more just about the vocabulary we use to describe different implants. And I want this to be a reference for you guys as well. This is not something you're going to memorize all right away, but hopefully you can come back to this and kind of get more additional understanding as your knowledge progresses, and so does your experience. So let's start with some basics about screws. So there's many, many different kinds of screws. And one thing I found really helpful during my training as a medical student and as a resident was to spend some time at the back table with the scrubs techs or the reps and get start to look through the different kinds of screws. Hold one screw next to each other, learn the difference between a cortical screw and a cancellous screw, and really look at them next to each other and see the difference and feel the difference in your hand, and learn how the different screwdrivers interact with the different screws, learn how the screws interact with different types of plates. And then, observe the attendings and the experts that you're working with use these in the body and start to understand kind of what are the pros and cons and when is it most appropriate to use one or the other. So this is really kind of how you progress. But let's just start with the basics. So principles of the basics. So you'll notice in the center image that it's important to understand that there's a core diameter and an outer diameter of the screws. And the reason that's important is because you'll hear us call for different drill bits. And so in general, the drill bit you're drilling with is primarily the drill bit that corresponds to the core diameter of the screw, okay? And then the size screw that you ask for corresponds to the outer diameter of the screw. And the idea, of course, is that you want to, drill a hole for the center of the screw, but you want the threads of the screw to be able to catch some of the bone around it. And again, the difference between the core and the outside diameter of the screw, which changes based on the size of the screw and also on the implant company, is really important because, as you'll see in the next couple of slides, it really impacts the way we use these devices. So again, drill size corresponds to the core. So for example, in very basic small frag or basic sets, which are considered 3.5 millimeter sets, then for many of the implant companies, that means that the screw has a 2.5 millimeter core diameter, 3.5 millimeter outer diameter, and so you're going to use a 2.5 millimeter drill bit. And understand that may, the difference between core and outer diameter changes a little bit amongst the implant companies, so just important to be familiar with what you're working with. But that's the principle that you need to understand. So understanding the difference between cortical and cancellous screws. So on this picture, you're going to see a cortical screw is on the left and a cancellous screw is on the right. And the idea is that cancellous screws have a wider pitch, which means the threads in the screws are further apart than they are for cortical screws. And so they have a larger outer diameter of the screw for the same core diameter. So for example, if you drill with a 2.5 millimeter drill bit, then you could put in, for two screws that both have a core diameter of 2.5 millimeters, the outer diameter of a cortical screw that goes with that might be 3.5, but the corresponding cancellous screw might be 4.0. And so what you'll see is that we tend to use cancellous screws in places where you are drill and you're trying to put in a 3.5 millimeter screw, you're not getting a great bite. You can some people will use it as a rescue screw, so to speak. Other people more commonly use it in areas of cancellous bone where the bone density is not as high as it is in an actual cortical area. And so having a larger outer diameter for the same size core diameter is then very advantageous when you're trying to get good purchase in cancellous bone. But I want you guys to, next time you're in the operating room, ask the tech. They come in the same set, if they'll show you the difference between a cortical versus a cancellous screw, and you'll be able to see the difference. And so understanding how that difference is important and what the utility of that is very important as well. So on this x-ray, you can actually see the difference. So in this x-ray, this is a patient had a distal fibula fracture that was treated with 2 lag screws. Those are those oblique screws that you see on the lateral and on the AP, and then a neutralization plate. And so proximally in the fibular shaft, the cortical screws were used. And distally, in the more cancellous bone, which is less dense in the distal fibula, then 4.0 millimeter cancellous screws were used. So remember, these screws, two screws have the same core diameter. So you can measure the core diameter of this cortical screw and the cancellous screw. They have the same core diameter. But the threads, or the outer diameter of is much wider. Well, it's 0.5 millimeters wider on a cancellous screw. And, because of surgeon preference, they happen to use 2.7 millimeter screws. So in this particular system, for example, a 2.7 millimeter screw, that's the outer diameter is 2.7, the inner diameter is 2.0. So, different drill bits kind of for a different process there for a smaller screw. So another term you might use is a cannulated screw. And so what's the difference between a solid and a cannulated screw? Well, a solid screw is drilled, you drill the core diameter, you put the screw in. A cannulated screw is inserted over a guide wire. So the idea is that you have a much smaller guide wire that you place, and then you're able to drill with a drill that has a hole because it goes over the guide wire. You drill with the drill, and then you can actually insert the screw over the guide wire as well. So pros of this is that it may increase the precision of your screw placement because it's a very small diameter wire that can then be placed precisely in the bone, and then the screw follows that wire. And it may increase speed as well because you've put that there and you don't have to worry about, am I being collinear with the drill, drilling with in the same trajectory as I wanted to, placing the screw in the same trajectory as the drill path, etc. So those are potential advantages. However, it's important to understand the reason we don't use them all the time, and some surgeons choose not to use them almost at all, and that's because these screws, because the core is hollow, they have decreased resistance to bending and torsion, and so that makes them ultimately a weaker screw. And the idea is that you have an increased inner diameter one idea also is that you have an increased inner diameter because you have to accommodate the fact that screw is placed over a guide wire, and that decreases the surface area of the threads. And so as a result, there's decreased pull-out strength of that screw. And so again, the screw does not only is the screw itself not as strong, it doesn't have as much resistance to bending and torsion, but it also has decreased pull-out strength, which means it doesn't have as good purchase in the bone. And then the last con is increased cost. That could be related to the screw itself, or it could also be related to the fact that you need to have the guide wire and the drill bit and all these other things. So again, you're kind of paying for more implants, which is an important factor when you're, when you leave training and are on your own as well. Okay, and that certainly impacts cost for patients as well. So again, I think where I see cannulated screws used most often is that often they'll be used for compression of non-displaced articular fractures. So for example, you have a patient that has a tibia fracture, for example. These are all the same patient. So you see the tibia fracture kind of at the top right x-ray, or the far right x-ray at the top of the screen. And they also have a non-displaced posterior malleolus fracture. So this surgeon has decided to put in this surgeon has decided to put in a cannulated screw to help kind of keep that fracture non-displaced while the tibial nail is being placed. And so first goes the guide wire, which is what you see in the left-sided picture, and then you can see kind of this A to P. So the surgeon is then, the middle picture is showing that he or she is just kind of keeping that in place and measuring the location or the screw. All those little squiggly things are just the drapes. And then you see in the very middle picture that the screw and washer have been placed, okay? And so what the x-ray on the far right shows is that if you actually look right down it, you can see the hole in the fracture site, and that is, and that kind of reminds you that this is in fact a cannulated screw. And obviously now that I look at these are not from the same patient because the first screw is placed from P to A, second one's placed from A to P, so forgive me. But these are cannulated screws. So two more major topics left. The last one is lag screws. And this is what I alluded to earlier where, you can get interfragmentary compression through three mechanisms: through compression through a plate, through lag screws, and either lagging by technique or lagging by design. So lagging by technique basically means you're using a solid screw to perform interfragmentary compression. And there's two main steps. The first one is that you drill what's called a pilot hole. And this pilot hole or gliding hole corresponds to the outer diameter of the screw. So we're going to use the example of a 3.5 millimeter screw again. you're going to drill a 3.5 millimeter hole through just the near cortex. So you're just going to the fracture site, okay? And then the second step is that you drill a hole corresponding to the inner diameter of the screw through the second cortex, okay? So past the fracture site. So first, outer diameter drill goes to the fracture site, smaller, which is the inner diameter drill, goes through the far cortex. And the idea is that as you place your screw, so first you're creating a gliding hole and then you're creating your thread hole. The screw, because it corresponds, the gliding hole corresponds to the outer diameter, is not going to grab into the bone at all. It's going to slide right through. And it's really only going to grab the bone on the far side of the fracture site, and then it's going to pull that bone toward the screw. And as the screw head impacts the bone, you're going to get compression at the fracture site. So again, insert a screw of appropriate length. It's going to glide through the near hole, or this gliding hole in the near cortex. And then as it engages here, it's going to pull the bone toward it so that as the screw head contacts the bone, then there's compression across the fracture site. So this is called lagging by technique, because you're using a solid screw, but you have a little bit more work to do because you're having to drill two different holes based on what you know about the core and inner diameters, the core diameter and the outer diameter of the screw. Okay, the second type is called lagging by design, and this employs a partially threaded screw. So the screw is designed to perform the exact same task as what we just described, but the screw is designed in this manner. And so this is a partially threaded screw. This is what we use partially threaded screws for. And so you just drill with one drill with the core diameter, but the smooth bore of the screw, which is on the near side of the fracture, serves as a gliding function. So it doesn't have threads that engage the bone. So essentially, as the threads in this partially threaded screw engage the far cortex, it does the same thing, and it causes compression across the fracture as the screw head engages the cortex as well. All right, you guys see how you can, with two different techniques, lagging by technique or lagging by design, the same. And so these, lagging by technique, lagging by design, compression through the plates, these are how you get interfragmentary compression, which gives you absolute stability at the fracture site. And then the last thing I want to mention is locking fixation. You guys will hear when you're in the OR, like, oh, I want a locking screw, or we need a locking plate. And again, the locking plate and screw mechanism is actually just refers to how the plates are machined. And so the plates are machined so that the screw heads actually thread into the plate. And this means that the strength is at the screw plate interface as opposed to the bone plate interface. These other plates rely on kind of friction or contact between the plate and the bone, but this really relies on the strength of the screw as it threads into the metal plate. And so it takes kind of away the necessity of having outstanding contact with the bone. And so it creates what we call a fixed angle construct, meaning the screw will only thread in one way, and it creates that fixed angle. So like this would be 90 degrees. And depending on how the plate is machined, it could be different angles. And if you're off angle or off axis, then that means that the screw head is like cross-threaded in, and obviously that's not advantageous, right? So the idea is that the screw threads into the plate, and that gives you this fixed angle construct. And so the low loading forces from the bone are transmitted from the bone to the screws, and then to the plate, and back to the screws into the bone. So it does not depend on the bone plate interface or on the strength of the underlying bone like it does with cortical screws or these other plates types that we talked about, because the strength of a locking plate is really given by this kind of the fixation of the actual screw head twisting and locking into the plate itself. So important to understand. And again, there are situations where it's advantageous to use locking fixation. And we use it in people with poor bone quality. We use it in the metaphysis where there's cancellous bone, which often is not as strong. We use it in elderly patients, in periarticular fractures, sometimes when there's you can use it when there's like a very long area that needs fixation, like sometimes people will use them with bridge plates, for example, because you have a very, very, very long fixation or length of bone that needs to have the fracture fixed around it. So again, or if you want to create a fixed angle construct, meaning it's very important, like around the joint, that you have this. So Again, important in some areas, not important in others, but just understand that this has to do with how the plate is machined as opposed to how you're using it. So again, short articular segment, poor bone quality, bridging of very common due to fractures, indirect fracture reduction, need for a fixed angles construct. And so here's just a couple pictorial examples, so to speak. So this patient has OI, osteogenesis imperfecta, on the left. And so a locking plate was chosen here for this bridge plate type construct because she had, because you can see all these little screws clustered by the joint they're machined to be put in exactly that angle. And because of her poor bone quality, this was felt to be kind of a necessity for this patient. In the middle picture, you have a distal humerus fracture. It's extra-articular, meaning it does not appear to go, it does go into the joint. It's intra-articular, but the distal fragment is very short. And so the screws that are in that short fracture are locking screws, meaning they go into the plate in kind of a fixed angle design, and that gives it additional strength. And again, you've seen this x-ray before on the far right. This is that very common femur fracture where the whole length of the femur has been bridged. And so it's important that you get good fixation above and below it. And so this surgeon opted to use a locking plate as a bridge plate. So it gave him option to lock the screws distally, but he chose to use it as a bridge plate.